Behind every high-performance healthcare system, there is a pilot that helps to scale. Dr. Ronn Berrol did not wait for a mandate. He used his insight to help emergency department to identify gaps and to connect the right technology with the right workflow. He helped Sutter Health to reduce readmission and workflow for the clinicians in the emergency department. This episode proves that you don't need to complete overhaul. You need one well-placed lever and the courage to pull it.
Welcome to Provider's Edge, the podcast that helps healthcare entrepreneurs and innovators break down barriers and control their business, life, and future with valuable action steps. With me, your host, Sabrina Runbeck, a recovered clinician and a business deal catalyst. Let's rewrite the rules and create a positive social impact while increasing your profitability. Welcome to another episode. We are at Point Click Care Summit with Dr. Ronn, and he has been a great movement creator in the space of acute care, in urgent care space, especially thinking about how can we leverage some of these solutions, getting more integrated so people can get the higher acutely aware of what's the next phase. Once they get into the ER, we did our assessments, knowing how critical they are. Where do they go from there? So Dr. Ronn, tell us a little bit more about your background. How did you get excited about emergency medicine and then being in the position of leveraging technology into patient care?
So, I'm Ronn Berrol. I'm an emergency physician at Summit Medical Center in Oakland through Sutter Health. And I was the medical director of the emergency department when what was then EDI, which has become EDO, part of Point Click Care now. But I was asked, hey, do you want to pilot this innovative platform that will allow you to share information about emergency department visits with other local EDs that you don't have visibility into? That was how it started. And because of that, starting and realizing we had these patients in common and beginning to identify patients who were circling through the emergency department, we began to start in some initiatives looking at high-risk patients. And it became the sort of thing which became very interesting, and it had teeth, and we felt like for the first time we had a way to approach some of these more complex patients. And that then led to us in Sutter saying, hey, we can use this for many different types of patients as well, whether it be patients who are visiting the emergency department frequently, patients who have behavioral health issues, substance use issues, and recently we've said since we've used it in this sort of patients, now we have these CMS requirements regarding readmission of CHF patients. Mm-hmm. We're now developing workflows that help us identify those patients as well and what may be failing in their care that's bringing them back to the emergency department frequently. So we're finding that we can use this platform for unique different types of high-risk patients. And I've given some examples, and as I said, you can also use it for diagnosis-specific issues as well, such as CHF readmission.
A lot of time I feel like when we're in the ED, I remember even picking up some of the extra shifts there as a part of either the hospitalist group where we can quickly admit patients in the hospital after they've been determined that they need a higher level care so that we can speed up the process versus being in the ED part, helping the triage. So we definitely see a spectrum of people, and we all know services usually used are the high risk, probably the 20% of all the high risk, but driving a lot of time, resources from both the clinical side, the cost to the hospital, and then also once we escalate that, then the entire system have a burden to support them. So having a solution be able to quickly identify who they are and create these care pathways is something definitely very significant. And how long was that study done back then?
I'd say there's been different iterations. A lot depends on how healthcare changes. And one thing that's been nice about this product is as local hospital administrations, governmental regulations have changed, CMS initiatives have changed. We've been able to use the same platform to address different proofs of concept and studies. So I would say our initial study was really just with one other hospital, and that was over 6 months, and looking at cost and utilization. And since then, we've had a different iterations of that. I would say the current, I think what relevant data for us is we took over our Sutter system. We started saying, if you wrote a care insight into a high-risk patient that you identified, and what you needed to identify them could be of your own discretion, each hospital's own discretion. But what we found was that if we looked into these high-risk patients and did a care insight, we found over the course of the year we could reduce the number of readmissions, the number of days in the hospital if they got readmitted, and more significantly, not more significantly, but it just wasn't about the admitted patients. If a patient was coming to the emergency room, we could decrease the amount of visits they had in the emergency room and the amount of time they stayed in the emergency department for each visit, meaning that bed was not being boarded or held as long, so you could get more patients into it, so you could decrease your left without being seen. So we've been able to study this and do a few different pilots and projects, but the data's been very impactful.
Yeah, and as a provider, I think that was my perspective of being in the ED, and then my reason of not being in the ED. I feel like all of us have a different personality, right? The driver, the people who love to be in the ED and practicing are the people who has that rush of like, what's the critical thing? Let me jump in, let's do things. I feel like that in the mental capacity, that's what you're saying, is that if people have the drive of getting patients out faster, seeing more people, there's also a stress towards that. So when we have these technology tools to help us to move things further, to see more, then the stress level is also going down. Versus me in surgical and being years in surgical place, it feels like it's not as urgent. And the only stress situation is I'm there at the patient's chest and I have that controlling. So with technology, it's really helping us to de-stress and better clinical decision and overall to move things in a quicker, more effective way. Were you also in the conversation when it comes down to selecting the technology and tools to make sure that's the right one before they running pilots or creating these additional pilots?
Yes and no. Basically, I will tell you that when we went down this journey with EDO, it was at a time when I didn't have insights into some of these other local hospitals. And when this was presented as a solution.
What we just heard from the first part of our conversation was that real change doesn't always start at the top. It starts with someone noticing a gap and deciding to do something about it. Dr. Ronn Berrol showed how one focused pilot helped reduce avoidable ED visits, speeds up care, and open capacity across 21 hospitals. The technology mattered, but what made us stick was having a champion who knew what information actually moves the needle. Now, if you are a founder with a minimum viable product and user base and want to present in front of active investors and decision makers from health systems and organizations, then apply to be a contestant on healthtechshowdown.com. Send us less than 200 words explaining about your solution and why you want to present in front of these amazing people. This is our matchmaking to help you to be placed and only talk to the people who care about your solution and already backed companies like yours in women's health, mental health, digital health, sleep medicine, age tech, diagnostic, or healthcare education. Now, let us get back to the rest of the episode.
I remember saying, I would love to have this technology, but I won't be able to because we won't be able to afford it. And actually, the charitable foundation wing of our hospital system said, if you're interested, I will pay for a pilot. And so that's how we started it. And hospitals are very interesting. They're not going to try too many pilots. So if something has teeth and it starts to work, then you're going to go all in on that. And that was more how it involved with us in terms of it was working, so we went all in. It was offering something different than our electronic health record had. I think that's a common misconception, is that often you hear people say, well, I already have Epic. Why do I need this? And I would say to them, you probably aren't a clinician then. Because, one of the things this tool does, it allows you to say, I need this information about this high-risk patient. I'm going to put a care insight in, so if someone needs to get that later, they don't have to go through the pain that I had to treat them in that place. Because we know that an EHR, such as Epic, has endless amounts of information. But your ability to synthesize it, process it, and filter it, you probably don't have time to do that. So now we have a tool that we say, this is a patient we identified who's high risk. They need a more intensive touch. Let us also put in the critical information that the next 20 people who see this patient can easily get. And when I say easily, it's pushed to them and they can go through it in 30 to 45 seconds. I will tell you that if you try and do a chart biopsy, as we would term it, on a complex patient with all the information that's in an EHR such as Epic, to do it properly is probably take you 30, 45 minutes. What we do is we do it while the clinicians are sleeping or aren't there. We've identified the patient. We get our committee together and we say, what's the critical information that they would need to know? And then we put it where it's easy to find. And that's the difference, is that we can push out the information that we feel someone needs to know, that we've all agreed upon is the critical information to determine if this patient is back in crisis or if things are failing in their life that's put them in crisis, such as housing or ability to get their medicines. So that's kind of the difference in how we use it and why it is distinct from an EHR.
Yes, the point being, all these point solutions or any type of company who wanted to break into a health system, for example, is that what are you solving in this unique way for us as clinicians, for patients, for caregivers? What's that pathway looks like? If you present yourself too similar to an existing solution, then of course it's a no. But if you can present it into this very reasonable pilot and get the buy-in, then we can continue to build on that and then work with the clinicians to create that dialogue of how to shape this direction of the solution. And at the same time, then is people like you, right? You were the champion. So when you're champion change within your department, then the system leaders can say, okay, if you really want this, then we'll back you, right? So having that critical identifying what could be, right? And then having a champion within the change will actually be able to create those pilots. Otherwise, if at the time they didn't present a solution that's valuable and you didn't say yes, or there's a bunch of other possible pilots that's presented to you, then maybe you went to a different direction, right? Isn't that the most critical point, is that just that people needed to have a better dialogue on what do we need as clinical team before they just approach us for possibilities?
Well, what I might say is that we're always being challenged with new goals. And then you have to say, what are the tools I have, the technologies to achieve those goals or to understand a patient or a diagnosis or CMS measure. So sometimes understanding what the ask is of you, you then can say, what tools do I have to solve that? And what I would say is we have found that this platform, EDO, is often the tool to help us approach these new measures and new criteria and new goals we have. You will try and use your tool that you already have in hand to face the problem. We're lucky in that we have two tools that really allow us to work well. One is our EHR. If we ask it the right questions, and it takes a lot of work to ask the right question, we can get good information. Then also having the other tool that allows us to consolidate the information and make it easily accessible and quickly accessible and push it to providers. We've been able to say that we can use these two tools together in tandem very efficiently for many problems. But one of the issues is that once a health system has a tool, it takes a lot for them to decide, let's get another tool. What we were able to show, though, was that through our pilots, this was an effective tool, and it started at my hospital, but now it's being used at all 21 of our hospitals within our healthcare system, and we're being asked by other healthcare systems, hey, show us what you did or how you're using this tool, because you're using it in a way we want to be able to use it.
Yes, and you become the example to leading the change. And that's what we're doing in medicine. We continue to evolve and then be able to be a student and be a teacher and then demonstrate the things that we found really useful. As we wrap up, I always like to ask a fun question. So if we gave you a magic wand and the magic wand grant you 3 wishes, what would you want to use the magic wand for within your current, either is Sutter based on the Oakland campus or the entire system?
Well, first off, I can't use it to have my kids spend more time with me, right? It has to be about medical stuff or things like that. Okay. Because, they're older now and they're like, we're doing our own things.
If you ever wondered what really gets a pilot off the ground, what you just heard in the middle of our conversation makes it clear. It's not always the tech. It's timing, traction, and trust. Dr. Ronn Berrol showed how one act of backing a hospital foundation funding a small pilot turned into full adoption across the 21 hospitals. Hospitals rarely test multiple solutions. They move when the first one proves its worth quickly. What made this one stick? It didn't try to replace Epic. It filled a gap by pulling forward only the most essential insights, so clinicians could act fast without being buried in data. Now, I would love to hear from you. What's one workflow blind spot your solution solves that bigger systems tend to overlook? Tag me on LinkedIn, Sabrina Runbeck, and let's have a conversation there. Now, let's hear the last part of our conversation.
But a lot of it is really access to care. So many of the problems we have are because people don't have access, and access can mean follow-up as well as getting their meds, a post-discharge follow-up, like so many of the problems that we have. The ED has become the ultimate safety net for everything. Mm-hmm. And if people had enough access, I think the ED would go back to the traditional role of, hey, you have an acute problem that you can't get care for right now and could be threatening your long-term health. Where do you go? The emergency room. So that access, I think, solves a lot of it. Similarly, a related second wish is most of the people went into emergency medicine wasn't because they want to be, I want to handle all your social issues that are going on. Yeah. Not that those aren't important, but I think we went to training thinking to learn about medicine. And when someone comes to the ER and it's about where they need to be placed, at that point, I can't help them because I've medically stabilized them. I need a system that is compassionate and resourced enough that then allows it to go to those places and not board or camp in an emergency room. So I don't know how well that fits in the wish, but I think I've wished for enough. That'd be a lot of magic from those.
Yes, to make sure people don't fall through the cracks, right. And when we discharge them, and then how do they get the social support, the housing, the things where they don't use the ED as, it's too cold outside, so let's just bank in the ED for the night and get food, versus the people who we really need to take care of the most critical and not drive up the resources. So appreciate everything that you have shared. When people wanted to contact you, or is there any ask that you want to support from the community at this point?
No, I mean, it's a pleasure to serve the community, to be able to be in the position to render care. People come to the emergency room when they're at a point in crisis or they're unsure. They don't know what to do. They can't control their life in a way they normally can. And they come to us and they give us the responsibility of helping them. And it's a great privilege to be able to do that. So I just appreciate that.
Yeah, amazing. Thank you. Is there any best way for people to contact you if they want to have a deeper conversation?
Well, I'm at Sutter Health, and it can be Berrol, BERROLR, at sutterhealth.org. And love to continue this conversation. And I've enjoyed the exploration, and I enjoy helping other people down the path of exploration as well.
Perfect. We appreciate your time. For anybody who's listening, we would love for you to comment, like, and then tell us how are you able to create some of these changes about running a pilot to really adapting some of the solutions and see how that can play into the bigger organization at play, and be a champion in your own mission and your own department, and don't see yourself small, because all of us can do something amazing no matter how we intersect ourselves into the healthcare space.
Great. Thank you so much.
In today's episode, I sat down with Dr. Ronn Berrol to unpack how a single hospital pilot became a 21-site success story. Not by replacing Epic, but by solving one thing it couldn't do well: surfacing the right data at the right time for the right patient. We dove deeper into how high-risk patients can be flagged before they escalate into crisis, and how real-time data sharing across emergency departments can dramatically reduce admission and improve workflow. Oh, and this secret ingredient? A clinician champion who didn't wait for the committee to say yes. He created momentum from the floor up. Here are the key things we discussed today. Number one, don't confuse your EHR with strategic insight tools. Dr. Ronn shared how even the best EHR system like Epic can bury physicians in data. What made a difference wasn't more information, but surfacing the right information at the right time for high-risk patients. Number two, champions create change, not system alone. Technology alone didn't earn trust. It was the clinician like Ronn who pilot, saw value, and advocated upward that drove full-scale adoption across 21 hospitals. Number three, pilot first, scale fast, but only when it works. Many hospitals hesitate to adopt new solutions unless a clear ROI is shown early. That's why the Origin pilot funded by a hospital foundation was a turning point. Number four, care coordination starts before the crisis, with tools that flag social risks, housing instability, or medication lapses. This platform helped avoid ER boarding by addressing patients' needs before they spiraled. Number five, modern innovation means cross-hospital collaboration. Emergency departments often operate in silos, but a real breakthrough came from sharing real-time data across unaffiliated EDs. Number six, you don't need to solve everything, just what others miss. What made this solution a win wasn't trying to replace an existing EHR system. It filled the gap that it couldn't do, and therefore surfacing actionable insights faster. Now, have you ever been the first yes that helped the innovation take off in your organization? I would love to hear how you have been a champion.
Thank you for tuning in to Provider's Edge podcast. We hope you enjoy our latest episode and found the insights and tips helpful. We'd love to hear your feedback on the show and learn what topics you'd like us to cover in the future. So please take a moment to leave us a review on your favorite podcast platform and let us know what you think. Your feedback is essential to help us improve the show and provide you with the content you need to take your healthcare business to the next level. Thank you for your support, and we look forward to hearing from you soon.